Welcome back to the deep dive. Today, we're getting right to it, talking about two crises that you, as an emergency medicine professional, are facing every single day.
Mm,
On one hand, there's the relentless operational battle in the ED, the crowding, the delays, the burnout. And on the other, this much bigger existential threat of climate change.
exactly. And they are more connected than you might think.
So we've taken the Royal College of Emergency Medicine's Green D initiative and we've put it alongside the greener NHS strategy, and we're going to try and answer a pretty critical question.
Which is?
How do you even begin to think about getting to net zero when your department is already, running on fumes?
Well, that's the thing. This isn't some far-off problem. The environment is changing fast, and it's a direct threat to patient health right now. And the numbers, they really make it clear.
Go on.
The UK's healthcare system, on its own, is responsible for about 4% of the entire nation's carbon footprint.
4%, that's significant.
It's huge. And the mandate for change is already locked in. The NHS was the world's first health service to commit to net zero way back in 2020. And now it's a legal requirement for integrated care boards, the ICBs, to deliver on this. It's not optional.
Okay, so our mission for this deep dive isn't just to talk about policy.
No, not at all. It's to really analyze the RCEM roadmap and show that moving to sustainable emergency care is actually probably the fastest route to improving quality and efficiency.
Right, let's pivot right there then, from mandate to opportunity. How do we sell this vision, this low-carbon ED, to a clinician who is just trying to get through their shift?
That is the crucial question.
Yeah.
And the RCEM position statement, I think it frames it perfectly. It calls the climate emergency a healthcare crisis.
Which it is.
But it also shows that when you allocate resources to net zero targets, you're not taking them away from patient care. You're actually investing in innovation that makes your practice more efficient, more timely. They're two sides of the same coin.
So how does RCEM actually translate that big idea into what you do day to day?
They break it down into three core pillars. First, staff need to understand and measure their impact. You can't change what you don't measure.
Okay.
Second, leadership has to embed this as core business. So that means, having a nominated sustainability lead, a green ED group. And third, and this is the most powerful one for me, the most sustainable healthcare is the healthcare that's no longer needed.
That third point really pushes EM professionals into that public health space, doesn't it? Prevention.
It does.
But let's stick with that middle pillar for a second. Embedding it as core business. You hear, create a new group, and immediately think, oh, great, another meeting, more admin burden.
I know, and that's the trap. But it's not about that if it's focused on quality improvement, on QI.
How so?
Because high-quality care is, by its very definition, efficient. Look at the Getting It Right First Time program, GIRFT.
Yeah.
Their work in emergency medicine showed that improving patient flow and just getting things done in a timely way led to huge operational gains. We're talking a 30% reduction in surgical admissions in some places.
And that kind of improvement in flow, that has a direct carbon saving, which makes the business case.
Absolutely undeniable, because when you avoid an admission, you're not just saving a bed day, you're saving emissions.
What kind of emissions are we talking about?
Well, the data from the RCEM sources is pretty stark. Just 24 hours in a hospital bed has a carbon footprint of somewhere between 37 and 85 kilograms of CO2 equivalent.
That's a huge range.
It is. It depends on the intensity of care.
Yeah.
The point is, any QI project that shaves off length of stay or prevents an unnecessary admission, well, that's a massive win for the planet and for the budget. That's how you get senior management on board.
Okay, that sets the strategy. Let's get down to the shop floor. Let's talk about the top 10 tips. Where does a busy ED start looking for these carbon hotspots?
Right. You have to focus on the areas with disproportionate impact.
Yeah.
Two clinical areas jump out immediately.
Okay.
First is inhaled gases, specifically nitrous oxide.
And
Exactly. It's a potent greenhouse gas, and often it's used just out of habit. A really quick win is just switching off the centralized manifolds that supply the ED when they're not needed. It stops all the passive leakage.
simple infrastructure check, huge return. What's the second and probably more surprising one?
Inhalers. We have to talk about inhalers. It's about switching from metered dose inhalers, the MDIs, to dry powder inhalers, DPIs, wherever it's clinically appropriate.
And the comparison here is what really hits home, isn't it?
It is. Think of it this way. A single standard Ventolin MDI 1 puffer has the same carbon footprint as driving an average petrol car for 175 miles.
Wait, say that again? One inhaler, 175 miles.
175 miles.
Yeah.
It's a stunning figure. Most staff would just see a kg CO2 number and it wouldn't mean anything.
But that comparison is unforgettable.
Exactly. And now compare that to a salbutamol DPI, the dry powder version. Its footprint is equivalent to just 4 miles.
4 miles versus 175.
That difference is the most compelling argument you can make for changing prescribing habits, especially on discharge pathways.
And this isn't just about respiratory meds, it's about pharmacy and prescribing routes in general.
Absolutely. Think about IV paracetamol. It's convenient, sure, but is it always clinically necessary in the ED?
Usually not.
OneTrust looked at their annual use. They found it had a similar carbon footprint to 7 return flights to Perth, Australia.
7 return flights to Perth for paracetamol.
Once you frame it like that, defaulting to oral medication or rationalizing blood tests, it stops being a green initiative and starts being a mandatory efficiency measure.
Which brings us back to that hierarchy of change. The biggest impact is reduction, just not using something, then reuse, and only then recycling.
And that's where sustainable QI comes in. It's a methodology that forces you to make sure every change improves patient care and reduces consumption. Reducing unnecessary cannulation, reviewing blood panels, these are perfect projects for junior doctors to lead.
Okay, so let's talk about the easy win people always jump to, recycling. But it's not that easy in a hospital, is it?
It really isn't. You need to know your specific system. The sources really stress doing a waste walk. Literally follow a piece of rubbish from the bedside to the bins outside.
And what do you find?
You find what can actually be recycled in your trust, because it varies. In many places, the plastic wrappers from syringes, cannulas, IV bags, they can all be recycled, but staff just assume they're clinical waste.
So you need clear signage, training,
Non-negotiable.
and the waste walk also uncovers those massive institutional horrors that are hidden in procurement.
Those are the huge wins waiting to happen. For example, OneTrust stops an order for 87,000 plastic water bottles a year.
87,000.
A year. Just by making filtered water more accessible for staff and patients. It just took a couple of emails.
That's not a department. That's a small lake made of plastic.
Or crutches. Think about crutches. Patients bring them back, but there's no system to clean and reuse them, so they just get thrown away. Fixing that is a direct financial saving. It's just common sense.
Which leads us to the biggest hurdle of all, securing buy-in. How on earth do you persuade an exhausted workforce staring at a 12-hour queue to start worrying about inhalers?
You have to make it easy.
Right.
And, more importantly, you have to show how it actually reduces their workload.
Right.
Giving tablets instead of drawing up an IV saves time. Not taking unnecessary blood saves time and effort. That's the incentive.
And for senior leadership, it's a different sell.
Yes. For them, you target the drivers that matter. Money, compliance with their ICB 5-year plans, mandatory targets. The Green Knee Day pilot showed that getting senior support was absolutely critical.
And sustainability is now appearing in consultant appraisals, right?
It is, which makes it a professional necessity, not just a nice to have.
So once you've got some initial excitement, how do you keep it going? How do you build a green group that doesn't just disappear when the trainees rotate?
2 things. First, you need permanent staff. And second, it has to be multidisciplinary. You need everyone. Doctors, nurses, porters, estates, management, domestics.
Why everyone?
Because everyone sees a different part of the problem. You need the estates team to actually go and fix the nitrous manifold. Yeah. You need the domestic team to make sure the recycling bins are in the right place and being used correctly.
And how do you communicate with all these different groups?
Not by email. The sources are very clear on that. It's ineffective. You have to use the channels people already use and trust.
Like what?
Handovers, staff WhatsApp groups, quick, bite-sized teaching sessions, and you make it a standing item on the ED governance agenda. You bake it into the system.
And finally, you have to shout about your successes.
You have to. You measure your success and you translate it. You turn carbon savings into those easy-to-understand numbers, like the car mileage for inhalers. That's what keeps the momentum going.
So what does this all boil down to for you, the professional listening to this? We've gone from the big NHS net zero commitment all the way down to these really practical clinical steps from RCEM. The Green AD framework, it seems, it's not just a tool to cut emissions. It's a tool to tackle the systemic waste and inefficiency that makes emergency care so difficult right now.
That's the key takeaway. Achieving Green E status isn't an extra burden. It's fundamentally about delivering higher quality, more efficient care. By focusing on reduction, you improve flow and you cut out unnecessary interventions. Everybody wins.
Which brings us to our final provocative thought. The RCEM position says emergency care professionals have a role in decarbonizing society. It also says the most sustainable healthcare is care that is no longer needed. So the question is this: how effectively can your ED use its trusted public platform to actually influence wider public health measures in your community and start to reduce the need for emergency care in the first
Hmm.
place?